Good afternoon, Dr. Seb. Welcome to the podcast. I'm super excited to have you on here. I'm glad we were able to coordinate our time. So how's everything going?
Oh, thank you so much. Yeah, I'm looking forward to the winter break, that's for sure. It's been a busy year, but no, it's getting closer now. So loving
Now,
it.
how
It's going
long do you
well.
take for winter break?
Not long for me. I'm only off Friday, Saturday, Sunday, Monday, Tuesday, working Wednesday, Thursday, Friday, back in the following Tuesday. So I've only really got the bank holidays. That's it. But I've got 10 days off in January, so it's all good.
Perfect. Well, yes, I'm so excited for everybody to learn about you. I found you on Instagram. Your Instagram page is fantastic. All the reels and videos, the educational content you're putting out there.
Nice.
Us myofunctional therapists definitely appreciate it. So thank you. And if you want to start by just sharing about yourself, who you are, where you're from, what you love to do.
Good question. So I am a dentist in the UK, and prior to dentistry, I studied biochemistry, and my journey was I was very ill, basically, and after studying the biochemistry degree, and I went on my own healing journey and through pharmaceuticals and through, natural therapies and really finding a place for both of them in my life. And actually that then made me think, well, what did I always want to do with my life? And it was a dentist, but I didn't get the grades first time. So then I thought, well, I'm going to go back to dental school and do dentistry with my take on how I live life. And, I always say in my world, in the biological dental world, there's 4 pillars. And one of the foundational pillars is myofunctional therapy, growth development, sleep disordered breathing, the airway piece of dentistry. So that is like 1/4 of what I believe. And we're so excited here because we can actually influence how kids grow and develop. So they have none of the same problems we all had with our braces and our headgear and our extractions and just the things you don't want, right? So when I learned about this, it just made so much sense. And it was a big part of my career now. Is it you hearing?
Did your dog hear my dog?
Yeah.
Sorry about that.
My doggy is a puppy. I'll get him. Here he is.
Let's see. Oh, how cute. What's his name?
His name's Arlo, and he's a Cocker Spaniel.
Oh, we have little Kobe Bruce here, who's a Yorkie, but the one that you heard barking was our Golden Retriever.
Nice. Go on in.
Sorry about that.
That's okay. That's okay. So yeah, so the myofunctional therapy, the airway dentistry makes up 1/4, and I've now. Sorry, I'm gonna shut the door.
Yeah, no worries.
Okay, he's in his bed now. So a big part of it, and now because a lot of my mentors in the biological dental world, they miss this piece out. And for me, this piece is foundational to healing, because if you have infections in your jawbone, if you have root canals that are infected, if you have metals in your mouth, your body can handle it much better if you are sleeping well and if you are regenerating at nighttime, right? Because that is how we recharge. So if we don't recharge at night, you're not going to be able to handle life stresses as much. So for me, it's a foundational thing. All of my patients now, since probably COVID, I did my new patient consultation and changed screening for everything. So my screening now has this, everything, and we can talk about what I screen for later, I guess, but it has my whole first section is sleep disordered breathing and what I look
that's incredible. Now, is this something that is it like paperwork for your patients to fill out? Is this something you're doing like in the room with you, or how does that work?
I developed this, I don't know if you've heard of Kuroku software. I think it might just be in the UK, but it's like dental recording notes, but you can kind of pick out what you want to look for. And I have it on the big screen, so all of the patients can see what I'm screening for as well. So I wonder how many times I've done this, and I can reel it off the top of my head. But the first thing is the Cottle's maneuver, how collapsible your nasal valve is. Then the Mallampati score and the Friedman tongue position, and then we're looking at the opening of the airway, the jaw, its deviation or its deflection. So all of these little things that just add up to maybe airway issues and or signs of clenching or grinding. I go through periodically with them so they can see exactly what I'm looking for. And I talk about, what does that mean? Oh, that means you've got a higher risk of this.
Right.
Is your elongated uvula causing you snoring? You know, all of these type of things. And when you really have it on the screen and you talk them through it, there's not one patient really that gets to the end of that treatment plan, because I used to do it by just looking at the signs and then sending them a report. But then when you don't walk them through each of the signs that they've got in that chair, then they don't really get it. So it's revolutionized the way I do things.
That's incredible. Now, in your training, like here, we learn often somebody clenches and grinds their teeth, they're stressed, we're going to put them in a traditional night guard. Obviously,
Yeah.
once you dive into the airway field, you learn root cause. But is that something even in your training in the UK that you guys get as well? Patient is stressed, they're clenching and grinding, put them in a traditional guard without really thinking about what it's actually doing to the airway?
This is it. It's not even root cause, is it? You're just kind of protecting the teeth. You're masking a symptom. And actually a lot of the time they're grinding more, their masseters are more hypertrophic,
Right.
or their temporalis is more tender, and you're actually not getting to the root cause. And me and this type of dentistry that I try and practice and educate people on is peeling back all of those layers to actually find out what the foundational thing is. And this is so huge for me, because my mentor John Roberts in the UK is a big founder of all of this, and he's got a famous presentation in the UK, and he does it at the IAMT webs conferences, and it's called Not Just the White Stuff, which is basically like, not about teeth anymore, right?
Yeah. I like that title. That's catchy.
I stole it.
I love it. That's fantastic. And then, before we got on recording here, you were talking about your introduction to, I think you said it started with Myo Brace. Do you want to talk a little bit about that?
Yeah, so Myo Brace for me was a safe, easy place to start, because not much can go wrong. It's a detailed program. You get an application for all the kids, and you're just walking through the cases that are easy. And obviously, over years, you realize its capabilities are not, and you have to influence things yourself as well by spotting when the time's right to add, build-ups onto the teeth to, allow the top jaw to be secluded, and, XYZ. But Myo Brace for me was really foundational, because in the UK there was maybe one practice. It's about 4 years ago, maybe 5 years ago. I'm 20, gosh, we're only 23, aren't we? So yeah, gosh, it was beginning of 2019. So yeah, a long time ago. And it just made sense, because when I was actually I hadn't made my transition to fully private, fully biological dentistry back then. So I was looking at, all my patients that I saw in the National Health Service in the UK, being like, it's ridiculous. Like, they have to pay for a night guard or a bruxism guard, which costs them £250. And in the NHS, and some people can't afford that treatment, they're used to getting things for free. So it's not even included on the National Health Service. I'm like, oh my gosh, how can I see all of this stuff and not try and help my patients? So in the end, I was buying the Myo Braces, the adult Myo Braces, is my like, cause it cost me £50.
Yeah.
And I just knew how much it would help their life and how much they'd be able to sleep more. And yeah, no, the conference is amazing. I listened to some amazing speakers from all around the world and learned some really interesting tips. And then I just put it into practice in kids, in adults. And it, I quickly realized that you can like biohack / shortcut in adults to get you to a better place. But in kids, you see changes so quickly. Right. You don't see changes in teeth, you don't see changes in jaws in adults, but you see changes in their sleep, and you've just got to look for the different signs, right? And that's why the the questionnaires that you have your patients fill in on do you sleep well, are you tired, all of the Epworth scores and all of that kind of stuff. It's really qualitative data that they can see, and actually, and posture changes is amazing. I love taking postural changes, and tongue position changes and head tilt changes, and all of these things that you don't realize how much your body compensates when you don't have a patent airway. It's just unbelievable, isn't it?
And it's, I don't know if you feel this way, but I know for us and, my practice, we take our initial photos, then we take mid-progress photos and final photos, we'll put them side by side. And sometimes even from the beginning to the middle, the patients don't really see the changes. And then you show them the pictures and they're like, what? That's what I looked like? I'm like, yeah.
How often do you take them? I typically do every 3 months, roughly, pictures.
Yeah, essentially, because we're doing, like I said, beginning, middle, and end. And typically our programs are like, it should be 4 to 6 months. but it generally takes 6 to 9 months just because it's out and things like that.
True.
Because, you know, I feel like, especially with myofunctional therapy, it's not the type of therapy where like you're going to do 1 or 2 sessions and already see these crazy results, right? It takes some
Right.
time. It's a lifestyle change. But to be able to have that change that they can see, and even different measurements that we take, I feel like it helps keep them motivated to
Yes.
then finish out the program, because the program does take a little bit. It definitely is very, it's a commitment, time, energy, mental, physical, emotional. There's a lot of components in it. Now, I'm assuming that there's a heaviness on nutrition in your practice. So do you want to talk a little bit about, I'm sure you talk about like diet changes and gut health and, you know, the microbiome and all of that.
Yeah, absolutely. And I guess that just picks into overall well-being in general, which then promotes better bony remodeling in adults and then better bony growth in children, right? So my original book, and this goes back to my wife, because my wife had 4 orthodontic extractions when she was like 16, and she didn't really need them. I looked at the pictures before, and she had the world of problems, headaches, migraines, chronic back pain. I mean, I remember her being in this in London on her laptop, looking, you know, trying to do. I mean, this is actually still one of her ergonomic mouses that she's got from that time in London.
Wow.
And they were just trying everything because they thought it was her position of sitting, when realistically it's what she was doing at nighttime without even knowing about it. But she was anxious all the time. She was depressed all the time. Her emotional state was everywhere. And she was early to mid 20s. So like really, she should have been in a good headspace, right? She just got this high flying job in London. And yeah, I can't believe how much that plays a part on, and we're not taught this. And I think that's the problem. A lot of the orthodontists, especially the older ones, the younger ones coming through now are seeing it, but they don't understand how that can cause these subtle changes because it's not the same for everyone.
Right.
That's the problem. It depends on whether they've had their tonsils out, their adenoids out. Do they have space at the back of the throat? Is their tongue large? Do they have a big enough jaw to have teeth removed, and the teeth are big enough to hold the space still in the dental arch? So there's so many of these different factors that, you know, pot luck, I guess, in orthodontics, just to straighten the teeth. But that was what opened my eyes to nutrition, because my other half was like, right, I need to expand my jaw, but there was no one in the UK. So this was like 2015, 2016. And she read about the Homeoblock online. She read about the Alpha appliance. She read about Damon braces, but no one was offering it in the UK. There was maybe a handful of retiring dentists that had tried a few things, and not with her, but nothing hugely successful, until she found this one guy who was in the middle of the country, like hidden away, he was a holistic dentist, but he wasn't really advertising that. And he had done a craniosacral therapy course as well. So you knew that he was open to movement of the cranium, and my wife had studied that as well. She's a craniosacral therapist, and that's what got her better. So through her changing physically and neuromusculature, changing where her jaw position was, she could actually hold her jaw in a bit of a position that she wouldn't get the migraines as much as she used to. And then she found a dentist that studied the same course, and he just expanded with an Alpha and then finished with Damon braces. And I mean, minimal migraines, you know, since those time. But during that process, she was on the hunt for the Western A price diet, right? And the diet that is highly nutritious, got your fat soluble vitamins, got all of your minerals and shuttling minerals and nutrients into the right places in the body to help with the remodeling that was going to occur by pushing on the teeth in the right way. So yeah, no, it's really fascinating stuff. But we have an ebook for kids and adults, and we we do the normal diet stuff and see how they go, and if there's active disease there, you know, and then we've got an ebook for them to follow, which is pretty good. But then we love the one by Ask the Dentist, you know, the microbiome reset.
Yes.
28-day one. Yes. Love that.
Absolutely. Now, what kind of appliances are you using in your office? I'm sure there's a bunch of different ones, but if you want to talk a little bit about that.
Yeah, so I guess being a baby, we use Myo Munchies and Myo Chews really young to try and stimulate that. Obviously, releasing tongue ties, releasing lip ties if problems feeding, but also if we see something in the mum and dad, because in England you have to be quite careful, because really the only thing validated for tongue tie release is feeding problems, right? So we always have to put feeding problems down. But even if mum and dad have read about this, right, and know how it's like the epicenter of growth and development and structural and skeletal alignment, we still have to put that, which is just ridiculous, isn't it? But anyway, so tongue tie release, but in kids, obviously you do it young enough so when the breastfeeding is happening, they're still able to change their, I guess, oral motor habits, right, to accommodate the new growth. And then as they get older, and whether or not they had a tongue tie or not, probably below 6, we tend to do the Myo Munchie, just to get them into the Myo Munchie and start doing that until they can comprehend. Normally find that young girls can do exercises more complex than boys. So girls, we start between 4.5 to 6.5, and boys we start between 5 and 7 or 8, depending on when they start to understand it. And we generally do 9 months of the Myo Brace program to get them through that. And the Myo Brace program is coupled with, well, for me, you need the foundational things there, right? Because if you're going to change the position of the teeth and you move them outside of their current neutral zone, you need to change the neutral zone into one that's going to keep the teeth in the position that you're trying to move them into, which is why braces so often fail and why people's habits never change if you don't change them. So, and then of course, if someone's got a crossbite or crossbite, I normally just put build-ups on their E's and D's so they can open their bite a little bit, so I can expand the top jaw while they're doing it, the Myo Brace program. If there's not much work or not much happening, then I will either use an ALF, which the active lightwear functional appliance, or the 3D Schwartz appliances, because they're pretty sturdy and they stay in and kids don't break them that often. And normally I do the Corkhouse measurements, and that's what I go by, the measurement of the front 4 incisor teeth, see roughly how big the other teeth are going to be and what width they should be and how far the protrusion should be. And I normally over expand to 1 or 2 mil above that, because obviously there's always an element of relapse. And then as they get older, I either do RN sagittal devices, ALFs, or Damon braces coupled with it to straighten the teeth afterwards. So yeah, quite a few appliances. And some kids, when I first started going off, I would have tongue spinners and all of those type of things. And now I don't do it, and I just teach them exercises and tongue clicks and tongue pops and whatever alongside it, rather than trying to scare their tongue away from doing what it's used to do or not.
Well, yeah, and those appliances, they're blocking really where the tongue should really truly learn to rest, right? A lot of them are covering that incisive papilla area, and if they're not getting that tongue to palate stimulation, it's not great. And I've seen so many kids still just get around the crib. So what's even the point? It's not teaching them the correct position. You're teaching them the wrong position, while I guess maybe keeping the tongue back if it actually works. But what about when you remove it? If the tongue doesn't, learn new patterns, it's just going to go back to doing what it was doing before. 100%. So absolutely. Now, tongue ties, are you releasing those in office, or do you guys refer out for those?
I personally release like 6, 7, 8-year-olds when it's not been spotted early enough, and adults when I'm expanding their jaws. But my mentor John releases under 1 and under. A long time. But yeah, we use the BioLays, Waterlays to release the tongue ties in infants. Yeah, although on my to-do list is Dr. Zaghi's course to learn the more surgical techniques.
Awesome. Oh, that's so cool. You'll love it. It's a great course. And speaking of adults, what are you doing expansion wise for adults?
Normally either RN sagittal, ALF, or Damon braces. But before I do that, I do what I call airway stabilization, which is doing the myofunctional for probably 3 or 4 months first. So, and it actually just consists of the standard exercises really that I give to kids, but also there's a device called the myotalia from Myo Brace, which I get them doing 5 minutes in the morning, 5 minutes in the evening, and just until they're worn out, they can't do any more. So they know where their tongue position should be, and at nighttime, right before bed, they should know where their tongue position should be too. So that's kind of how I do it with adults. I try and keep, I have done some cases where I've not done the myofunctional therapy, and I just think it's taken so much longer And this is me a couple of years ago, and I'm getting towards the end of the cases now. I'm like, you just shouldn't do it. You
Right.
just it's
Got to
funny.
get that functional part in. Now, how does it
Absolutely.
work in the UK as far as like sleep studies go?
So we have BTI ones. We have there's actually websites that you can get reviewed. I think it's called sleeptest.co.uk, and you get this sent to you for 3 days, and
Mhm.
you wear it in your own environment at home, and then the doctors review it, and then they give us a score. And we treat anything from moderate sleep apnea downwards, really. And
Okay.
we have to work with doctors that don't often believe in the
Oh
this type
yeah.
of thing if they're
Yep.
productive.
Now, have you gotten any kickback from other providers in your area doing what you're doing?
Not
Or
yet. Touch wood.
that's great. And I'm going to give your name. I actually had a mom reach out to me this morning from the UK. I mean, I don't know where she is exactly, but I believe the child was 1.5 years old.
Wow.
Well, let me see. I don't exactly remember what the problems were. I want to say, silent reflux. What else did she say?
It's hard when you're that young, though, isn't it? What do you typically do for kids that young in your practice?
Yes. Well, generally, I mean, I'm really lucky to have a really great ENT in our
Right.
area that I referred to. So generally making that referral first, making
Yeah.
sure there isn't any major obstructions,
Yeah.
that need to be taken care of, no allergies that are causing that chronic congestion. I also have a local provider that will start on 2-3-year-olds, really more 3-year-olds probably, for putting like expansion devices in and getting
Wow.
expansion started. I'm not sure if you're familiar with Dr. Kevin Boyd. He's a Chicago-based pediatric dentist, but he teaches a lot of early intervention. So
Wow.
I'm lucky to have somebody in my area that will do that. But it's a tough age, because when it comes to the myofunctional therapy component, cognitively, right, they can't understand what it is that we're asking of them. So it depends. A lot of it's based on the parents and how they respond. A lot of it's parent education and giving them different little tips and tricks that they can do at home. We would definitely incorporate a munchie at that age,
Yeah.
to your point, just to get them started on something that is going to
Yes.
help promote good function. But the age is tough, even when it comes to tongue ties.
No.
Depending on how that post-op care is going to work following that tongue tie and the active wound management, we have to take all those things into consideration. So it's
Hard.
always a tough age to treat.
Really hard. Yeah. I mean, you want to pick it up as soon as they're born, really, don't
Of
you? But then,
course.
of course, yeah, there's so many blockers in education. You don't know what you don't know.
Exactly. And then, I don't know how it is for you guys, but oftentimes what happens here is, they'll see me, or they'll see one of the doctors that are within our team here that are more airway focused, and we'll point out X, Y, and Z, tongue tie, tonsil enlargement, crowded teeth, recommend expansion. And then they go see their pediatrician, and the pediatrician will say, oh, that's fine that they're clenching and grinding their teeth, or the tongue
They'll
tie,
grow out of it.
they'll grow out of it. They'll fall and rip it. It's not a big deal. Or sometimes even the ENTs. And that's why I fight so hard for my families to go to the ENT that I love to work with, even if it's a 45-minute drive and you have a ENT local. I mean, I'd love to build a relationship with whichever ENT they want to go to in their area, but it's tough to find an ENT that is airway centric and that's just going to listen to what we're saying and be communicative. That's like the biggest part in this. Like, we have to communicate on these patients, right? I mean,
Yeah.
I just talked about this at a conference I was at. I mean, how cool would it be for a parent or family to come in and know that I'm talking to you, you're talking to me, we're both in contact with the ENT or the pediatrician, and everybody knows what's going on at all points of everybody's discipline.
100%.
I mean,
Yeah.
that would just be the coolest thing. How comforting would it be, and how trusting, how easily it would be to put parents' trust into our hands. You know what I mean?
Absolutely. And it's the thing that's most often missed. No one
Mhm.
does it, really, and it's hard. And I think you guys are much further ahead than us in the UK. I don't even have an ENT I can trust yet.
Mhm.
So I
Well,
have
I'm
actually
definitely going to send that child your way, because you know, if anything, to just be able to grow up in a practice that is more airway centric and is holistic, you know, and put them on a better trajectory, and you can get them started in whatever you can once they're age appropriate.
Yeah,
I don't know if
that's
they're being seen by a dentist right now or what, but I'm
it.
definitely going to give mom your contact information.
It is interesting. Thank you for that, by the way. But it's interesting because I have a few American patients that have obviously moved across to the UK, and they're like, Seb, can we not just start expansion yet? I'm like, honestly, I don't feel comfortable doing it in anyone under 6. Like, it's outside of my comfort zone at the moment, and I don't know anyone I can refer you to in the UK either, which is even worse.
Yep. Yeah. I'm not familiar with anybody either, to be honest. It's tough. And once, you know, you want to be able to help all the patients, but it takes time, right? You don't want to like trial on somebody's child until you feel comfortable doing it. So it's tough. I completely understand. It's got to be tough because you know what the trajectory of their life will be if we don't intervene. But when there's not providers in the area, it's tough and it's frustrating. It's exciting when you find those people, right? Like I always say to the providers that we network with that are like in our little team here, like it's like Christmas morning for me to be able to find you, because I know how much we're going to be able to impact people's lives and change lives.
Yeah, 100%. Send me some of that energy, please.
You got it. Is there anything else that you'd like to talk about before we wrap up?
I guess for me, what's your thoughts on rapid palatal expansion? How often do you guys use that? Because there's, you know, Mike Myo, who's obviously pretty influential in the world of orthotropics and all of that stuff. I was speaking to him a couple of months ago now. Time goes quick. And he's really incorporating that into his practice now. But for me, I just think, God, it looks so barbaric, you know, in a way. Splitting the midline. I just think,
Yeah, I mean, I think that I have a lot of providers that use it. It depends. You know, some people are okay with having that slower growth.
Yeah.
In that case, you know, an ALF might be best suited for them. I think like symptom wise too, we really have to take those symptoms into consideration and weigh those pros versus cons, because obviously we're going to get more benefit quicker with rapid palatal expansion. I mean, we've gotten some really great results with RPE here, really on, you know, all ages. You know, doctors that are even doing MARPE, you know, and placing those TAD screws to split the suture on adults. I just think for us, you know, it's so hard when the problem for me sometimes that I have providers that make the referral, which is great. I always appreciate the referral, but I need tongue space. It's very hard for me to be successful in my job if there is literally no room for them to park that car, right? They need to have that real estate up there. So it's hard because there's all different philosophies out there. And if you're working with a more traditional orthodontist, you know, they're taught to expand later. So, you know, you kind of just have to work with what you have, but honestly, the kids do well with the RP. I know like the whole idea of it sounds barbaric, like thinking about and saying, hey, you're going to take this thing, you're going to crank it every day and it's going to, you know, split that suture apart. But the benefits that you're getting of it, you know, I think kind of outweigh how maybe scary it sounds. And the kids do well. I mean, really, honestly, the kids that I have that go through it, of course, you're going to feel a little bit of tension and stuff once you crank it. But nothing that they can't handle.
No, good. Yeah, it's good to get your view on it because it's just too many courses for me to do, isn't it? That's the thing.
There's so many courses and so many different philosophies, and this appliance is better than that appliance. And really, it's the patient. It's patient-centered care. It's what appliance is best for the patient, because not every patient's going to benefit the same from a certain appliance.
No, that's it. No, it's it's good. And ultimately, all you're doing in any of these expansion techniques is giving yourself space so you can keep the tongue in the roof of the mouth, so you can create a good seal, so you can breathe through the nose, and you've got less of a high vaulted palate to do so. So but you know, it's really interesting when I have in fact, Friday I had a 32-year-old patient that 4 teeth out, and you just think, how am I going to get his tongue to fit in that roof of the mouth without taking a long time to do so? There's not a quick solution, is there? So, but maybe I need to learn that RPE and then get in there quicker.
Yeah, there's definitely if you follow you might already follow them on Instagram, but Dr. Mariana Evans and Dr. Rebecca Bacco, they're both dual certified orthodontists, periodontists. They're talking about MARPE a lot. Dr. Audrey Yoon. We have a
Amazing.
provider in Tribeca in New York. Dr. Lena, I'm gonna totally screw up her last name if I even try to say it, but I can send you over some of those resources because
Definitely,
again, I think for adults, we can only take them so far by tipping teeth.
Yes. Yeah. That's it, isn't it? Ultimately. So you need to change the skeletal structure sometimes when there's not enough room at all.
Yep. I also just at the conference I was at, there was a orthognathic surgeon there, and we were talking about the importance of the two of us really collaborating more, because I really enjoy working with patients post-orthognathic surgery. But the problem is sometimes they need more expansion is what I'm seeing at times. Their tongue's not fitting there. Or they're tongue tied, and it's like coming up with this protocol that just makes things work a lot smoother. I tend to see them when they can't open, when their range of motion is restricted and they can't get scanned for their Invisalign or whatever they need to get scanned for. But if we can have something in place where they're doing some pre-op to try to optimize their current function, given their current structure, get things a little bit stronger, have them have the surgery done, once they're back on some kind of solids, get them back into some myo, because if you think about it, we're completely changing their occlusion. And that's what I hear from these patients. It's like, my mouth is so foreign to me. I don't even know what to do with anything.
Yeah. It's really important, isn't it? I'm amazed by, like, even I had no teeth out for my orthodontics, and I still, after going on that myo race course, I thought I'd do myself myofunctional therapy for 18 months. I couldn't fit my tongue in the roof of my mouth until I used the homeoblock. And that was just like, what? And all I've done is tilt my teeth out, and now I've got space.
Yep.
But it's just absolutely unbelievable that even the standard conventional orthodontics, it kind of like just makes things smaller to make the teeth less gappy, when really I had gaps for a reason. My wisdom teeth would have had enough room to come through and then push my gaps together if I hadn't have narrowed the arch back then. Yep. What's weird is that I got out of my braces with 6 months to go, because I was boxing quite high up back then, and I was like, it just doesn't it's not good for my system. I need to get out. So I wonder how much more narrow my jaw would have been if I hadn't.
If you stayed in. I know. And that, that's the crazy thing. Like, I never had braces. I have perfect class 1 occlusion.
Yeah.
But I'm narrow. I mean, I look at my buccal corridors.
Yeah.
My teeth and it's gotten better. I actually went through some Invisalign before my wedding, and we did some tipping, obviously, and I gained some space, and I ended up having to get my laterals bonded. But I'm still narrow. I mean, look how much my tongue occludes over my teeth.
Yeah, I'm the same.
Yep. Yeah. So I know I need to go into expansion. Sometimes we're the worst patients.
Yes.
But for me, I'm not functionally impacted, really, which is why I think it hasn't been a necessity for me. Yes. Just the fact that it annoys the living daylights out of me as I'm taking my myofunctional therapy exercises to see my tongue. I'm like, this is what you don't want your tongue to look like. See mine? Yeah. You don't want that.
Yeah. All of it at the roof. Yeah, it's so satisfying, isn't it, when you see kids with their flat arches and you just think, oh, if only I could have that level of suction when I swallow.
Right? Awesome. Well, thank you so much for coming on. This has been incredible. We'll definitely link all your pages, your website, your social handles, all that good stuff, so people can find you, because to your point, there's not a lot of people doing what you're doing in the UK. So hopefully, especially that mama I talked to this morning, hopefully she'll be able to make the drive to you.
No, I hope so. And yeah, I'm planning on, there's lots of interest, especially with the Instagram, growing nowadays, that, students get to see these things now, right? Yes. And they think in their head, makes sense to do things like that. Why wouldn't we do it like that? So then I'm getting lots of young students coming in and shadowing. And so hopefully it's not going to be too much longer in the UK, right?
That's amazing. That is so good to hear. All right. Well, thank you again, Dr.
Thank you for doing what you're doing.